something about debating. But we're not going to really debate, but we'll talk about a couple of things that we hope are interesting topics, and I hope we'll leave some time for discussion. I was not excited to debate this smooth commentator, Dr. Ohman. So these are a couple of things we'll touch on. One of them is the complexity around use of P2Y12 antagonists given both different patient populations and risk and economic issues and adherence issues, and we've unfortunately seen the challenges of how we integrate, of the challenges of integrating new effective therapies, but ones that have challenges in terms of, including in terms of financial reimbursement. This vexing problem of how we treat the patient who needs to be on warfarin and gets a coronary stent, and questions about, other questions about P2Y12 antagonists and how long to use them. And let me start out with this case, 76-year-old woman presented to the CCU with acute coronary syndromes, has a history of comorbidities including CABG and stents and prior TIA, asthma, presented with increasing chest pain, including in the emergency department, and was treated with nitrates, morphine, beta blocker, had some wheezing, a little bit tachycardic, mild heart failure, moderate renal insufficiency, and elevated troponin, and then some dynamic ST depression anterolateral and mildly decreased ejection fraction. So this is a high-risk patient with acute coronary syndromes, and we talk about risk scoring. I don't think you particularly need a risk score to know this patient's at high risk, but we do encourage people to do to use the risk scores, including the GRACE risk score. And why do we think that's helpful beyond the fact that as the human being, most of our minds, with the exception maybe of Neil, most of our minds are not really able to take kind of multifactorial parameters in simultaneously very well. And actually there's pretty good data. Sean Goodman has done some nice studies showing this, that when you just ask somebody about the risk, about what their gut feeling is about the risk of patients presenting with acute coronary syndromes, for example, even I think after stressing this, they don't take into account age adequately as such a dominant factor amongst other factors in predicting risk. They look at troponin and the EKG, for example, and so anyway, I think these risk scores are helpful, and in fact, the risk score there was elevated in that high-risk range of greater than 3% in-hospital risk of death. And so then some of the treatment options include, in addition to aspirin, what do we pick for a P2Y12 antagonist, for anticoagulation, for a cath strategy. And we're relative to the cath strategy, and I do believe these data. I was a co-author on this manuscript, but I tend to be skeptical of subgroups. But I think these data are probably real. And this was from the TIMAX trial. This was 3,000 patients who presented with acute coronary syndromes and then were randomly assigned to either an early cath strategy. That meant within 24 hours. And on average, it was about 15 hours. Or a later strategy that meant after 2 days. And that was on average a little bit after 2 days. And then the overall results of the trial was there was a 15% non-significant lower rate of death, MI, and stroke at 6 months with early cath versus later cath. But there was this one subgroup where there was a strong statistical interaction suggesting that there really was a substantial benefit in the patients at high risk with a score of at least 141, which again is a predicted in-hospital death of at least 3%. So here there was a big benefit. This raises the question, for example, of for a patient who comes in on Friday afternoon who now, and is high risk, we now wait until Monday to do the cath on that patient, given these type of data. Now this is a 2A recommendation, it's a subgroup of a trial, but would it be the best care if we, given the economic and resource realities, to have routine cath, for example, on Saturday for patients who have high-risk ACS? It's a quite interesting question, I think. So there's a lot of complexity in how we decide how to combine various strategies, including the cath strategy, whether we use intravenous antiplatelet therapy, which oral antiplatelet therapy, and which doses we pick, which anticoagulants, and then we're meant to adjust all of these decisions based on the risk of thrombosis and the risk of bleeding. So it's a lot of different combinations. And one of the ways that we believe is helpful to come up with at least a more systematic approach, maybe not the right approach or the best approach, but at least an approach that is consistent and based on the guidelines, is to have an algorithm that we use as kind of a standard, and then we still adjust that according to individual patients. But this is what our algorithm is that we've agreed to as an appropriate, more standardized approach. That is to use ticagrelor, and then if we use clopidogrel, consider increasing the dose for the first few days, which in the current trial was shown to result in lower rates of stent thrombosis. And then for patients who are high risk, including dynamic ST changes, positive cardiac markers, higher risk score, if the patient's going to the cath lab within 24 hours, then we typically use unfractionated heparin. Bivalirudin if a patient's high risk for bleeding and going right to the lab. And then for patients with delayed or medical therapy, then consider fondaparinux or enoxaparin. And the issue about the P2Y12 antagonists is we can do better than clopidogrel. And we can do better with one of two ways, either prasugrel, which in the Triton trial was shown to result in the 20% relative risk reduction in cardiovascular death, MI, and stroke. But this came at the cost of bleeding, including a small absolute, but an increase in fatal bleeding. And this is particularly the case with patients like this patient with prior stroke or TIA. So we do need to be sensitive to that issue. And then the ticagrelor data from Plato showing a 16% relative risk reduction in the primary outcome of cardiovascular death, MI, and stroke. But then this really interesting and unexpected reduction in mortality, so a 22% decrease in death. Now I'm reminded and told that we shouldn't say that we prevent death. We don't prevent death with treatments or in clinical trials. We simply postpone it. But ticagrelor, in fact, is a strategy which reduces cardiovascular mortality and total mortality. And the pattern of this curve, and Magnus will get back to this, is interesting in that there's an early separation, but then the curves appear to continue to separate over time. And the mechanism for this is interesting. It looks different than the other P2Y12 antagonists, this pattern, although I don't know, Magnus, maybe you'll get back to this, maybe not totally different, seeing a late separation in curves. But people have hypothesized that this may be related to the adenosine enhancing effect of ticagrelor that also relates to some of the side effects of breathlessness and AV block that we see as a complication of the use of ticagrelor. Another question that's been studied and that we have recent data but not going to make it through the FDA, it looks like, at least not in the near-term future, is this question about should patients who've had acute coronary syndromes, would they benefit from being on an anticoagulant in addition to antiplatelet therapy for this high-risk period during the next several months to a year? And we actually do have data with warfarin that warfarin prevents myocardial infarction based on the overview of randomized trials of warfarin versus control for patients with acute coronary syndromes. But the problem is it comes at the risk of bleeding. And these trials were before the use of clopidogrel and the other more potent antiplatelet agents. So this has not made its way into practice, but but it's interesting that there was a nearly 50% reduction in MI with warfarin versus control. And then this has been studied with rivaroxaban at lower doses than have been shown to be effective for stroke prevention and atrial fibrillation, showing a reduction, a statistically significant, a 16% relative risk reduction, about a 2% absolute risk reduction in cardiovascular death, MI, and stroke following acute coronary syndromes. This is most patients in addition to aspirin and clopidogrel. So it looks pretty impressive, and there is some benefit. And in fact, this was accompanied by a lower rate of cardiovascular death and all-cause death with the lower dose of rivaroxaban, the 2.5 twice a day. Remember, in atrial fibrillation, it's 20 milligrams a day, or 15 milligrams for impaired, for decreased renal function. But these results are pretty impressive. But this is the problem with rivaroxaban, is that it came at an increased risk of bleeding. And this is very consistent pattern with any time that we're adding one of these novel agents to aspirin and clopidogrel, we see a 3 to 4-fold increased risk of bleeding, including major bleeding, intracranial hemorrhage. So this is a real limitation. And in fact, if you kind of line up the results of rivaroxaban plus clopidogrel versus clopidogrel alone, you see about the same effect as ticagrelor versus clopidogrel, with a less of an increased risk of bleeding. So I actually think the FDA is probably right in being pretty cautious about approving rivaroxaban for this indication because of this risk of bleeding. Each of these treatments reduces stent thrombosis, including rivaroxaban, which is interesting. I think a lot of people wouldn't have predicted that. They thought stent thrombosis was a more platelet-mediated phenomenon, and the fact that it prevented it was interesting. Okay, so the lady now has coronary stenting with a Xience drug-eluting stent, and her creatinine goes up, not unexpectedly, and then she develops atrial fibrillation. And we go to Magnus and we say, why did you put in a drug-eluting stent in somebody with atrial fibrillation? He says, well, it hadn't happened yet, so we can't, so you can't blame me. But anyway, then we're up against this question of what do we do in someone like this? This patient has a CHADS VASC score of 7, a CHADS score of 4. What do we do? Do we treat with triple therapy, meaning aspirin, clopidogrel, and warfarin for a year? Do we stop clopidogrel after the necessary time for dual antiplatelet therapy after 3 months, but understanding that in acute coronary syndrome we have benefit for out to a year from randomized trials? Do we go with ticagrelor or prasugrel? Probably not prasugrel in this patient, again because of history of TIA, but ticagrelor. Or do we simply say that aspirin and clopidogrel may be enough, because that was shown to result in a 28% reduction in stroke in the active A trial compared to aspirin alone, and say that we're just not going to tolerate this, the excess risk of bleeding with triple therapy. And we don't know the answer to this, right? I mean, we'll go over what the guidelines tell us, but we just don't have enough information. What we know is one of the reasons this is a tough situation is we're in this conundrum because we have 3 potentially fatal problems, and we try to balance the risk of each of these. We have stent thrombosis, for which we need dual antiplatelet therapy. We have stroke, for which we need oral anticoagulant. But we add the 2 of those together, and we get very high rates of major bleeding. So there's no good choice here. Here, the CHADS VASC score, this patient, a 10 to 20% annual risk of stroke. So it's a high risk of stroke that we have a high priority to prevent that. The risk of bleeding, lots of different studies, both randomized and observational studies, showing this 3 to 4-fold increased risk of bleeding when we use triple therapy compared to, say, aspirin alone. It's a big risk of bleeding. And then once someone has bleeding, then you're in a real bind, because then you then you have to decide whether to stop things, and then the patient's at very high risk of thrombosis, so it's a real challenge. So here's what the ESC guidelines say, and this is consistent with the US guidelines, that this period of triple therapy may be needed, followed by oral anticoagulation plus a single antiplatelet agent. And after a year, and this is an interesting recommendation that's really changed over the past couple of years, and I think it's correct, that after a year, in somebody who has stable coronary disease and atrial fibrillation, that you should really strongly consider using the oral anticoagulant alone. And that's true for warfarin. It's a little bit less clear whether it's true for the novel drugs, but I think it probably is true for apixaban and rivaroxaban. I'm not so sure about dabigatran, where there's a signal for somewhat more MI with dabigatran than with warfarin. Using triple therapy for the minimum time to minimize this hazard of a 3- to 4-fold increased risk of major bleeding. That means 3 to 6 months after elective stent, certainly. After ACS stenting, a little bit less clear. Use low-dose aspirin. Be careful to avoid high NR. Probably use proton pump inhibitors. Maybe consider one that doesn't interfere with CYP2C9 like pantoprazole as a better choice. How about dropping the aspirin? Here we had this interesting study recently published in The Lancet called WOOS that was a small study, about 600 patients who had indication for oral anticoagulation and dual antiplatelet therapy with coronary stenting. Most of these patients had drug-eluting stent, even though they had indication for oral anticoagulation. Like 2/3 had drug-eluting stents placed. Only about a quarter had acute coronary syndromes. But the primary outcome was pretty clear that there's lower risk of bleeding when you drop the aspirin. When you just use clopidogrel plus warfarin, you have a lot less bleeding than when you use triple therapy. So it's interesting, and that was accompanied in this small study. I don't think this study is large enough and clear enough to really change practice. So I don't think we should be doing this yet as a routine. But there was even lower rates of thrombotic outcomes when dropping the aspirin, maybe somewhat linked to the issue of bleeding. So one of the themes then that is still maybe a bit controversial, but I think this is really true, is that we've probably underestimated the risk when we add all these antithrombotic therapies together, and therefore minimizing the duration of triple therapy and even of aspirin is reasonable. We had this interesting match trial that we kind of ignored, I think. This was a trial of patients who had stroke and then were randomly assigned after stroke to clopidogrel plus aspirin versus clopidogrel alone. So it's a little bit like WOOST. And in fact, in that trial, there was no benefit of reducing cerebral events with aspirin added to clopidogrel and a 50% increased risk of bleeding. So we got a couple of trials that suggest we should probably be more thoughtful. We've always considered aspirin almost to be an imperative. It's almost free. 81 milligrams of aspirin seems like such a low dose, effective and safe. But in fact, it's really not safe when we combine it with other antithrombotics and anticoagulants. And each of these trials, Active W, clopidogrel plus aspirin had exactly the same rate of bleeding as warfarin. We think of warfarin as a dangerous drug, and aspirin and clopidogrel is equal in terms of risk of bleeding. So one of the messages today is be more thoughtful about in whom we use aspirin. Maybe heart failure too, Joe. I think we probably overuse aspirin in patients with heart failure. Certainly with non-ischemic cardiomyopathy, where it may have an effect on ACE inhibitor through prostaglandin mechanisms. So maybe we've been a little bit too enthusiastic about aspirin. Here's just one recent publication, this from the RELY trial, with looking at warfarin, dabigatran, 150, dabigatran, 110, and then looking at bleeding rates according to whether patients also were on aspirin or dual antiplatelet therapy. And you see there's a 1.5 to 2-fold increased risk when you just add aspirin to warfarin, and then a 2 to 3-fold increased risk with dual antiplatelet therapy, this in a chronic population. But again, a consistent theme. So we need more data, and more data, the good news is more data is coming about this issue of patients who've had who have atrial fibrillation and have ACS or coronary stents. And there are several trials that are currently either being started or planned. This is one of them that Magnus is on the DSMB for, called Pioneer. It's a small study. It's only 2,000 patients looking at bleeding, but it's looking at rivaroxaban and a couple of different strategies. One is to use clopidogrel alone, and another is to use clopidogrel and aspirin, and then another is warfarin, clopidogrel, and aspirin. So I think this will add to the information at least about bleeding. And then this is my favorite design right now, which is to take patients who have had coronary stent and atrial fibrillation with risk of stroke, and to use one of the novel drugs versus warfarin, and then some period of time after the stent is placed, then randomly assigned to dropping the aspirin or not, to get a bigger trial and a confirmatory trial to this WOOS trial, including with the novel oral anticoagulants, to see if dropping the aspirin might be a safe and appropriate strategy. And I'm going to stop there, Magnus, and turn it over to you. And maybe we should wait for questions till the end.
Yeah. Thanks, Chris. So I'm going to take the more interventional look at the information and maybe deal with two other controversies, and that the first one being, should you switch? Many of us are getting asked, you started one of the new agents, and guess what, your pharmacy plan doesn't like it, and so you're going to have to switch. Should you do it, and what evidence do we have? And I'll share a little bit with that with you. And then the other vexing problem that we still deal with, how long should we use dual antiplatelet therapy in post-ACS? And the guidelines are very clear, but as you know, there's much more to it. These are my disclosures, some relevant for this talk. So some reflections on dual antiplatelet therapy. Chris has hit some of these. The duration of dual antiplatelet therapy after ACS is a balance of ischemia and bleeding. I mean, we can reduce ischemic events long term, but we also know that we can increase the rate of bleeding, and so this balance becomes very important. Other factors, though, that play into our practice a lot more is cost and compliance. How easy is it to take a therapy that you have to take twice a day versus once a day, for example? There is that desire to switch that I talked about, and then of course there's side effects to these besides bleeding to some of these agents. And I think all of this comes into our practice. So after PCI in ACS, dual antiplatelet therapy is recommended to prevent stent thrombosis and other ischemic events for typically 9 months to 1 year. It's a class 1A to 2A, depending on a little bit on which guidelines you read, but it's a very clear message. So anything less than a year for dual antiplatelet therapy is really not acceptable for PCI. Now, duration of greater than 1 year is a little bit more controversial, but you will find patients who are being treated much longer than 1 year, and I'll share with you a little bit about that information. There's some populations, though, where it's actually probably required, even though we don't have trials to tell us this, but recurrent stent thrombosis, for example, is one typical group of patients, and those who undergo high-risk PCI, such as left main or equivalent left main stenting with drug-eluting stents. So this is all for drug-eluting stents. So why would you ever consider switching to dual antiplatelet therapy? Well, one would be to improve compliance, cost being one issue. So it's really reasonable to switch to a cheaper agent because dual antiplatelet therapy is still better than aspirin alone, and we have many trials to tell us that. So dual antiplatelet therapy for switching, if compliance is an issue, is important. Reduce side effects, I think that's also important. It's reasonable, as patients tend not to be compliant with therapy that causes side effects in general. So those are fairly reasonable options. To save money, now here is a challenge, particularly as Chris has showed you, and I will show you a little bit more. Ischemic events occur, so if you switch to an agent that has been associated with higher ischemic events, what is the cost of the ischemic events, it may not actually cost the patient that much, because patients still don't pay for copay in hospital, but for the healthcare system or whatever, it may not save any money at all. And then, as we see somewhere around us, not at this institution, thank God, but as routine practice, you got to be kidding. There is no data for that practice. And then I'll share with you a little bit about that. So Chris showed you this. This is the randomized clinical trial of Triton with prasugrel after PCI and ACS. Very significant reduction in ischemic events and almost a 50% reduction in stent thrombosis, increased risk of bleeding shown at the bottom of the slide. So there is a risk balance to be played out here, but these results were achieved without switching after discharge. So keep that in mind. If you are going to try to attempt to get the same results, you really can't get that if you start switching. This is the Plato invasive. So Chris showed you the overall Plato trial. This is more for the invasive strategy, looking at ticagrelor over clopidogrel in this trial. And you see here for the primary endpoint, nice separation, although not separation very early on. Actually, in the first week or so, there is really no separation in this trial, but gradual separation over time, highly significant benefit. Chris showed you the mortality benefit, so this obviously stands out as a very positive finding and benefit for ticagrelor up to 1 year. Once again, these results were achieved without switching after discharge. So just keep that in mind as people talk to you about discharge. Now here is the data broken down from the invasive trial from Plato, looking at the first 30 days versus the second 30 days. And remember, most of the pharmacy plans won't actually hit you until day 31. And now you can see what happens. The curves actually separate, if anything, slightly more after 31 days in the Plato trial in the invasive arm. This event reduction would not be seen if you switch. So obviously there's important issues here about not switching. Chris actually alluded to this information a little bit. This is actually looking at all the major trials for reduction of stent thrombosis. And why do we interventionalists worry about stent thrombosis? Because in today's practice that we are in, it is the single most fatal event that we have. It's associated with anything between 25 and 50% reduction when it happens. So this is a fairly serious event. Thank God it's rare, as I will share with you. So preventing this becomes a big deal for us who practice in the cath lab. As Chris mentioned, high-dose clopidogrel, 600 loading with 150 for 5 days versus standard old-fashioned dosing, significant reduction in stent thrombosis. Prasugrel versus clopidogrel. Prasugrel is better for stent thrombosis reduction. Same thing with ticagrelor versus clopidogrel. The new kid on the block, cangrelor, that you heard about in last week's cardiology grand rounds, is actually better than clopidogrel. This is from an older study. And so what you see here is a very consistent message. Clopidogrel, while it's been a mainstay of what we have, anything newer has been better. So that's obviously what we are going to be interested in moving forward with these agents in this setting. Now, a few words about stent thrombosis. And this is actually the largest paper on this, published now a number of years ago. 8,000 patients with dual antitherapy for 6 to 12 months, which is sort of the average standard therapy across the world. Looking at the annual rate of stent thrombosis is about 0.5% a year. And the incidence rate is 1 per 100 patient years. So this, and you can see the curves here, fairly interesting. They are flat going upwards. So this is going to happen to some patients. Now, obviously, it doesn't happen to a lot of patients, quite rare, but when it does, as I mentioned, it's fairly fatal. Now, there's an interesting dynamic of when stent thrombosis occur after the dual antiplatelet therapy has been stopped, or in this case, clopidogrel, because this is what these trials showed. So on the left-hand side, you can see the change in risk of stent thrombosis with duration of clopidogrel. So for patients who were stopped early, oh, this pointer doesn't work, but on the left-hand side, you can actually see that if the stopping clopidogrel in the first 6 months, it takes on average 9 days before you have a stent thrombosis. If you treat for more than 6 months, that goes to 104 days. So it's actually much delayed in patients who at least take 6 months of therapy. And you can see the cumulative incidence of stent thrombosis on the right-hand side. As time goes on, you can see the major bump is in the first 6 months, but then after that it goes up a little bit after clopidogrel has been stopped. Now, if you go to things that drive stent thrombosis, and this is still a little bit controversial, this is what does the pathway for metabolism of clopidogrel play into the risk of stent thrombosis. And all of you are familiar with the CYP2C19 genotype and the risk for stent thrombosis. This is a paper by Jessica Mega, published now 2 years ago, looked at the increased rate, which is about 2 to 5-fold higher if you're CYP2C19 poor metabolizer. And basically, you can see that the 2 reduced functionality is quite rare, 2%, but this also carries out to those who have 1 reduced functionality, which is 26%. So you can see this, we know for a fact, is something that happens every day, and that's partially why the stent thrombosis rate goes up over time. This is actually looked at the 20% of patients with low responders to clopidogrel. Everybody had platelet function testing in this study. A large study of 1,600 patients. Low responder, you can see they have a almost 200% increase in rate of stent thrombosis from about 0.1 to 0.2% to nearly 3% over time. And the odds ratio is 5-fold higher, suggesting that low responders do get stent thrombosis in this setting. Now, is there an ideal cutoff for the use of platelet function testing in this setting? And as you know, Paul Goebel, one of our former fellows here and chief resident, actually has studied this a lot. I haven't taken one of his papers, I'm just taking another paper here, because it isn't entirely clear what the cutoff is. This paper suggests, as you can see here, if you look at early stent thrombosis and the interquartile range of final ADP on the left-hand side, the spread of those curves are fairly wide. They're almost twice as high between the lower and the higher end, suggesting that there isn't a single cut point. Having said that, over on the right-hand side, you can see that the risk of hazard ratio of stent thrombosis is actually related to residual platelet aggregation that you get, but it's not a linear relationship. It's actually curvilinear in this paper from Europe. So what data do we have then about switching acute coronary syndrome patients from prasugrel to clopidogrel? That's one of the papers I'm going to talk about, ticagrelor, in a second. This paper just came out about 2 weeks ago in JACC. It's a French study by Gilles Montescalot, and they basically had patients who responded well to prasugrel, and they then switched them from prasugrel to clopidogrel. And the conclusion was that we don't know if this switching actually unmasked a group of non-responders to clopidogrel with unknown consequences of clinical outcomes. But what they did show is that when you switch somebody from prasugrel on the left-hand side to clopidogrel, your PRU goes up. And so, of course, I've already mentioned that a higher PRU is more associated with stent thrombosis. And in fact, 29% of the patients here developed a high PRU level on clopidogrel, while none had so on prasugrel. And if you look at bleeding, because this trial was not large enough for looking at ischemic events, shifting patients away from prasugrel to clopidogrel actually indeed lowered the event of bleeding. This is using the BARC definition. but we don't know what ischemic events will follow with this. Unfortunately, to study this, you will need at least 10 to 15,000 patients. Obviously, it'd be almost impossible to study this. Now, what about ticagrelor? This is actually the data by Paul, switching ticagrelor and clopidogrel. So this is a little bit of a complicated slide. This looks at the PRU value, so the reaction to the agents on the platelet. And what you can see is that ticagrelor in red lowers the PRU quite dramatically compared to clopidogrel in green on top. At about the second, I think this is at several days out, 28 days out, patients are switched back. Those who were on ticagrelor get switched to clopidogrel, and those on clopidogrel get switched to ticagrelor. You see the colors change. And what you can see here is that very dramatically this actually looks at how ticagrelor actually lowers the PRU, and vice versa with clopidogrel it goes up. This study was only carried out in 60 patients, so we really don't have any clinical outcomes here, but you can see the fairly significant differences in platelet function as you switch between the agents in this setting. So is it reasonable to switch dual antiplatelet therapy? Well, if the alternative is aspirin alone, then yes, then I think that is reasonable with all the warts I've talked about. However, I have to say consistent therapy with dual antiplatelet therapy will mimic the randomized clinical trial. So if that's what we want to achieve, which I think it is, then we really need to stick with consistent therapy. And no randomized clinical trial in PCI have explored the switching strategies, but the platelet function studies suggest there may be a risk for adverse cardiac events. So now I'm going to switch over to long-term therapy in the last few minutes. I'm going to share with you some of this information from TRILOGY-ACS that we presented last year and bring you up to date on some newer therapy. One of the interesting things when you look at what we talked about here is PCI patients and the risk for stent thrombosis. And this is a paper from the Veterans Administration, paper published now a number of years ago, looks at the risk of stent or adverse events, this is death MI, after clopidogrel has been discontinued. And on the right-hand side, you see what happens in the PCI patients. It's exactly what I've shown you in all the other slides. There's a fairly large bump upwards risk within the first 45 days, and then it tapers off in the next 6 months. Over on the left-hand side is what happens among those who were treated medically without PCI. And here you can see the bump is much, much higher. Yet we have focused exclusively almost on the PCI patients. So the Trilogy trial was really set up to see could we modify this increased bump and treat patients longer term with a more potent therapy. And this is the trial design. This is medically managed, randomized 4 to 5 days after ACS. They were randomized to prasugrel versus clopidogrel, and we used a lower dose of prasugrel in those who were elderly, over 75, and those lightweight patients. Most of the time, about 96% of the time, patients were actually managed, started clopidogrel in the hospital, and then were randomized within the first 10 days. A very small group, 4%, were actually randomized within the first 24 hours, and they had no prior clopidogrel given. For all the other patients, they were on clopidogrel prior to randomization. You may have seen this data. This is actually from Paul Goebel's presentation at American Heart Association. This looks at the PRU value in 2,400 patients out of the total trial from baseline. And remember, the blues are the clopidogrel patient. They don't change because remember, the vast majority were on clopidogrel. But if you look at the patients that are randomized to prasugrel, there was a very significant drop, already a small change at 2 hours, but then it stayed remarkably consistent up to 30 months in this trial. So very effective therapy in this setting. You have seen this data before. This shows the primary endpoint in the under 75 cohort, and remarkable no treatment effect in the first 360 days of first year. Remember, all trials in this field for ACS have been stopped at 1 year. What we saw after 1 year is very interesting, but and we have really no other trial to compare it to. But what you see here, there is actually a borderline significant interaction with longer duration therapy favoring prasugrel in this setting. The hazard ratio was significant beyond a year. So this idea that longer-term therapy may have value, this is a hypothesis that may generate from this trial. I don't want anybody to use this information to use long-term prasugrel, because I think it's an important information that we need to study further. If you look at death, MI, and stroke, the three components of the endpoint, they all follow the same pattern. No effect in the first year, separation over time, and if you look at the breaking it down by within a year, after a year, you can see that it's very, very consistent with majority of the treatment effect seen in beyond a year in this study. Now, we did another analysis which was different, that hadn't been done before in an ACS trial. We actually looked at the multiple recurrent ischemic events. As you can imagine, a patient could have 2 MIs, then a stroke, and then die, or they can just die. And of course, if you're a patient and you have multiple events, that's less good unless you die, of course. So we performed this recurrent ischemic analysis using the Anderson-Gill method. And this was pre-specified, and overall, this was a significant treatment benefit in the trial as a whole. But interestingly, once again, it was actually more positive beyond a year, so showing more treatment effect long-term in this study. Now, bleeding was interesting here because Chris had already showed you there was an increased risk of fatal bleeding and serious life-threatening bleeding in the Triton trial. That was the PCI trial. Now, of course, our patients are older. They're managed medically. They have more comorbid illnesses. And in this trial, with the 2 modifications I share with you, we saw no increased risk in bleeding. There's a trend here using the Gusto criteria. If you include moderate bleeding, and if you use the timid bleeding shown here, really no signal to increase risk of bleeding. There's only when you have major and minor bleeding that this increased. So I think long-term prasugrel, at least within the context of this trial, appeared to be quite safe in this setting. And here are the curves, and you can see this separation starts at about 30 days, but the curves are pretty much parallel after this point. Now, we looked at some subgroups here that I'm going to share with you. The most interesting one is probably, because it's more pertinent to our practice, what about patients who have angiography prior to randomization versus those who did not, and then also looking a little bit about smokers and PPI. So in the total cohort, there was 9,000 patients and 7,200 under 75 years old, and about 43% had angiography prior to the decision was made to manage patients medically, and half of them were randomized to prasugrel versus clopidogrel. You can see here this is an international trial, and most of the patients that had angiograms before randomization was in North America and Western Europe, and some of the developed countries in Australia, New Zealand, and so on. And you can see as you go out to India, eastern parts of Asia, you can see that the rate of angiography goes down quite a bit, as is expected in a trial like this. Everybody, of course, thought that the patient would have sort of minimal disease, but in fact, in this trial, when we looked at the cohort that had the angiogram, you can see that about 40% had 2 or 3 vessel disease. So they had fairly extensive disease. Even 6% had left main disease. But yet, because of comorbid illnesses or other criteria, they were treated and managed medically. Only 7% had PCI or revascularization during the entire follow-up of 30 months. So this is a purely medically managed cohort. But when we break this down into the angio versus no angio cohort, some interesting features arises. First of all, on the right-hand side, you can see there's no treatment effect whatsoever in the patients randomized on that after no angiogram, begging the question, do they really have ACS? On the other hand, the curves separate, very similar to the overall trial, on the left-hand side, and in this setting it is statistically significant. If you look at the rate of myocardial infarction, same thing. Patients without angiogram randomized, no difference between prasugrel and clopidogrel, a fairly large difference among patients who had an angiogram. Interestingly, bleeding appears to be slightly higher in the angio cohort than in the no angio cohort. We don't have a good explanation for this, but at least it is there, and it seems to be staying about the same over time over the 30 months period. And if you look at major and minor bleeding, you can see that it's the same story, namely slightly higher in the angio cohort. Now, what about the PPI? And this, Chris alluded to this, that some clopidogrel has been shown to have an interaction with omeprazole and some of the other PPIs. And in our trial, in fact, if you were randomized to clopidogrel and were on a PPI throughout the trial, you were quite different than if the patient was randomized to prasugrel and were on a PPI. And our use was about 60% overall in the trial as a whole over time. And you can see there's a significant interaction. Jose Nicola from Brazil is still working on this paper that we're going to soon submit. And here is probably the most striking finding with smokers. If you're a smoker and you're on clopidogrel, and at least within the context of this trial, you have a very high event rate for death of MI and stroke. Very, very different if you were randomized to prasugrel. You can see the p-value for interaction. We still don't know this, exactly what the issue is here, but you can see at least these curves separate fairly early on and stay separated. And within the context of this finding, we actually had a lower mortality with prasugrel. So long-term therapy here, suggesting that at least prasugrel is a reasonable candidate to do, but from a safety perspective, but obviously the lack of efficacy in the trial as a whole is an issue. What about the randomized trials of duration of dual antiplatelet therapy? And this is the largest paper by C.J. Park, published now 2 years ago. No difference among patients who were treated with clopidogrel and aspirin versus aspirin alone beyond a year. This is the definite stent thrombosis rate. And this was a trial of a few hundred patients, so they concluded really that we don't know exactly how long to use this, and this should be confirmed in a larger trial in the setting. I just want to show you, because you're all Duke fellows, this is actually the Duke Cardiovascular Data Bank data on long-term use with clopidogrel and drug-eluting stents. And what you can see, if you have in red drug-eluting stents and no clopidogrel after 6 months, you have a much higher adverse event than if you were a patient that were in yellow drug-eluting stent and were treated with long-term clopidogrel. Now, this is not randomized. It was suggested and very careful analysis and published in JAMA, but this is at least our own data in this setting. And we're going to wait for this trial, which is the largest trial in this field. About 11,000 patients have been randomized to either have drug-eluting stents and then either have clopidogrel for 1 year or continue with it beyond a year up to 2 to 3 years. And this trial will be very important to ascertain what the long-term benefit is. It is interesting to me because most of our benefit in the TRILOGY trial was seen beyond a year. So in the overall context of the TRILOGY-ACS, among patients treated with medically for up to 30 months after ACS, prasugrel had similar bleeding rates as clopidogrel, with really no difference. But you have to remember, you have to reduce the dose to 5 milligram in the lightweight and excluded patients with TIA and stroke, and be careful in the elderly. We have an intriguing signal for reduction of CV death and MI and stroke after 1 year, but I don't know what that means yet. And hopefully more long-term trials will really try to help us understand how long we should use dual antiplatelet therapy. Thank you for your attention. I think Chris should come down and we'll take some questions.